right, I have the challenge of talking about monoclonal antibodies as well as cellular therapies. This is a lecture that every year is a little bit different. This year especially, there's been several recent approvals that we kind of shoehorned in here. But for time, we're going to kind of keep things moving. Sure, I can actually advance my slide here. For some objectives, we're going to review the basics of monoclonal antibodies, structures, and functions. We'll talk about the targets and mechanisms of actions of those that are approved currently for hematologic malignancies. We'll review dosing, toxicities, and clinical pearls for various monoclonal antibodies, though unfortunately this lecture used to be much more comprehensive. Now we are very much hitting the surface level of a lot of these agents. And then finally, we'll summarize with CAR-T manufacturing, available products, as well as toxicity managements, and some look-aheads for CAR-T therapy as well. So for a monoclonal antibody, I'm sure we are all very familiar with the structure and function here. These started as a research tool and have evolved into a pharmaceutical agent, and what I would say is kind of a cornerstone pharmaceutical agent, especially for the hematology sector. They have, of course, variable and constant regions. They have light and heavy chains, and they have complementary determining regions, or CDRs. And this, again, is kind of the template or structure that we'll start with, but these agents will vary significantly as we go along. I will try and highlight the structure in the upper right-hand corner of the slides as we go. This is more for your reference, but also just to show kind of the complexity of these agents. We think about things more simplistically with the small molecule inhibitors and things like that, but these are large structures that are rather complex. Here is kind of the old classical version of the nomenclature that can get you into the current FDA-approved monoclonal antibodies and kind of how they are named based upon what type or how human or humanized the proteins are. Rituximab is a really nice classical example of a chimeric or a monoclonal antibody that has mixed proteins with a human C region and a murine or a mouse V region. Some of you may know that the monoclonal antibody nomenclature is going to be changing. It was approved, the changes were approved, I believe, in 2021. I don't believe there have been any FDA approvals currently with the new suffixes, but coming down the pipeline, there will be 4 new suffixes for FDA-approved monoclonal antibodies, which will more closely mirror what they do as a mechanism of action. One of the examples is like, instead of rituximab, since the mab suffix has been overused at this point, Rituxan by mechanism, if they were to change these old ones, would be Rituxatug, which frankly I hate, but it's supposed to help more closely mirror kind of what the mechanism of action for these products are. They're not going to go back and change or update the names of products that are already FDA approved. But just so you're aware, this suffix nomenclature will be coming down the pipeline with new molecular entities. Here are some of the monoclonal antibodies and how they work or how they get things done. They can serve, like in the first column on the left-hand side there, as a receptor or ligand binding, which can lead to signaling or antagonism of signaling. They can lead to complement-dependent cytotoxicity or activation of the complement cascade. They can have antibody-dependent cell-mediated cytotoxicity, and they can even deliver payloads via antibody-drug conjugates. And then we'll also talk about the FDA approvals for the bispecifics and how they go about getting things done as well. We always have to start when we talk about monoclonal antibodies with the CD20, specifically rituximab, as this is kind of the old poster child. The one that everyone thinks about when they think about monoclonal antibodies for heme malignancies. These products are targeted against, of course, CD20, which is expressed on B lymphocytes. These bind to an antigen activating complement-dependent as well as antibody-dependent B-cell cytotoxicity. And they also have the mechanism of activating neutrophils and producing free oxygen radicals. The pharmacokinetics are a bit funny. The product lasts for a very long time in the body because it is a protein that is not easily broken down, with a half-life listed out at 20 to 30 days. But these act to deplete B cells, and that depletion can be 9 months or even longer, particularly with the rituximab products. Indications are here on the slide, though this is not comprehensive, as rituximab, as we know, is used for many off-label indications. The dosing's here on the slide as well. The most common rituximab dosing is 375 milligrams per meter squared, typically every 28 days. That will vary based upon the regimen that you're looking at, every 7 days, every 21 days, every 28 days. And then I'll try and highlight as much as possible pre-medication for the monoclonal antibodies as we go through them, though keep in mind that these are foreign proteins that will have infusion-related reactions associated with them, and as such, pre-medications will be very common with these products in any combination of an antipyretic such as acetaminophen, an antihistamine such as diphenhydramine, and then methylpred or dexamethasone is typically as your corticosteroid. I will also do my best to highlight black box warnings for these products as we go through. They will typically be bolded in black on the slides that are a little more condensed, but for your purposes, I've blown them out here on the slide. There is a black box warning, as we talked about, for infusion-related reactions, particularly with the rituximab product, although all of these products can have them. There's a black box for severe mucocutaneous reactions as well with rituximab. And we're looking at Hep B reactivation, and that's why screening for hepatitis B is recommended for all of these products and is built within our treatment plans here at UW Health when you look for them as well. There is a black box warning, though it's relatively uncommon for progressive multifocal leukoencephalopathy or PML. And we have several other toxicities that are listed here on the slide. Rituxan, I mean, we use it so much that you think of it as relatively benign outside of that B-cell depletion and hypogammaglobulinemia, but it does have several other side effects. The supportive care medications, Tylenol, Benadryl, and the things that we talked about earlier do help go quite a bit towards that infusion-related reactions, though we still have issues despite pre-medications with some folks. And then, of course, drug interactions will be highlighted on the slide. It's important to know that if B cells are depleted, you're going to have difficulty with immunosuppressants and live vaccines, and you're going to see that pretty commonly with our monoclonal antibodies kind of as we go through them today. I did want to take some time to highlight some moves here to help with cost and efficiency of healthcare. These monoclonal antibodies can't really have generics. We consider products that are relatively equivalent biosimilar, not generics. But there have been moves recently to move towards biosimilars within the monoclonal antibodies where we can to try and reduce costs, improve healthcare efficacy and efficiency. This is a nice study looking at a biosimilar of rituximab, which was IBI 301. This is a actual study looking at non-inferiority and toxicities and cost associated with this product as compared to the reference rituximab in R-CHOP versus the biosimilar R-CHOP for DLBCL. This is a paper that was published in 2021. What they found, you can find the paper, it's relatively interesting to look at, but what you can find is that in this study, they found non-inferior efficacy. They had similar toxicities, as you would expect, and it was much cheaper. And as such, these products, these biosimilars, can be used where they're approved to try and make care a little bit less expensive, because these monoclonal antibodies, especially as we get into the newer and fancier ones, are going to be very expensive products. Transitioning from the CD20 products over to a CD30 product, this is brentuximab vedotin. This is going to be our first example of a drug antibody conjugate. As a drug antibody conjugate, we have a monoclonal antibody. You can see it in the upper right-hand corner, that classical structure that you notice. In this case, it's an IgG1 monoclonal antibody that's targeting CD30 that is expressed on cells. We have a MMAE, or monomethylstaurin E, MMAE, which is a microtubule disrupting agent. Think about this as kind of like your classical chemotherapy. And then we have a protease cleavable linker that links the monoclonal antibody with this kind of chemotherapeutic payload. The mechanism of action here, you have the monoclonal antibody that will attach to any cell that expresses CD30. This kind of collection will be internalized into that cell. You will have cleavage of that linker, releasing the MMAE, the chemotherapeutic payload, and this induces cell cycle arrest and apoptosis, hopefully on a more specific cellular collection just cells that are CD30 expressing, as compared to just giving cytotoxic chemotherapy broadly and hoping that it more selectively goes towards malignancy. We're hopefully targeting that payload here with these drug antibody conjugates. The indications are here at the bottom of the slide. It is moving earlier in the therapy for Hodgkin's lymphoma. BV-ABD is the regimen that we think about here for frontline Hodgkin's lymphoma, BV being brentuximab vedotin, or AAVD is another way that folks say that regimen. But it does have kind of that first line approval here in some settings. Dosings here on the slide, 21-day cycles. The dosing is 1.8 mg per kilo on day 1. The black box warning to call out here is progressive multifocal and leukoencephalopathy. Some more common toxicities that you would expect is fatigue, but especially neuropathies can be quite limiting with the brentuximab product here. And you do see some of those more classical chemo side effects like nausea, vomiting, diarrhea, and count suppression here, which you wouldn't classically think of if you just had a monoclonal antibody alone. Another drug antibody conjugate moving to CD33 targeting therapies. Gemtuzumab ozogamycin is that product that is an IgG4 antibody targeting CD33. Again, we have a protease cleavable linker, as you can see on the upper right-hand side. And then you have a cytotoxic kalikiamycin derivative, which serves as your payload here. This is targeting CD33, same kind of mechanism of action that you'll see with the previous product and other products that we'll talk about here with these drug antibody conjugates, where it's internalized in that complex. You have that cleavage of that cleavable linker, and you'll have the release of the payload, the kalikiamycin derivative in this case, leading to, in this case, DNA binding, double-strand breaks, and cell cycle arrest and apoptosis. FDA approvals are here on the slide. We'll see this quite a bit with CD33 positive AML, as well as off-label for APL, or acute promyelocytic leukemia. Dosing's relatively complicated here, but if we're talking about in combination with 7 and 3, it can be dosed days 1, 4, and 7 on the slide as it's FDA approved. It can also be used in monotherapy, which it has approval for as well. Pre-medications are here on the slide, and please note the corticosteroid dosing per kilo. And then there's hepatic dosing restrictions, which we'll talk about here on this next slide here. This was a product that was actually approved way back in 2000. I'm starting to get old, but I was definitely not in the practice of pharmacy back in 2000. This product was actually FDA withdrawn back in 2010, and I have the very nice press release from Pfizer up above for that withdrawal. And then it was reapproved back in 2017. So it's a long history of regulatory issues with this drug. The brand name there is Mylotarg, as you can see. This approval was partially because of this black box warning here for severe hepatotoxicity, including veno-occlusive disease, or VOD, veno-occlusive disease of the liver. It does have other toxicities here. It can be quite difficult on blood counts and things like that, but it's used in combination with AML therapy, so that follows quite a bit. But some of the confirmatory testing or studies back in 2010 or the late 2000s found that those who received this product actually had higher mortality than those who did not. So that it was eventually pulled off the market. They kind of found a certain subset that it had more efficacy for and actually had a benefit for, and that's how it was reapproved back in 2017. But this is a product that kind of has been back and forth, and it kind of shows how the FDA follows up with a lot of these products and ensures that they have kind of the good data that supports their actual use. Moving now to some more contemporary FDA approvals. Loncastuximab is a CD19 targeted antibody drug conjugate. This is, again, CD19 expressed on B cells. This is conjugated to, again, a payload SG3199, no fancy name here. Binds to DNA minor grooves, causing DNA crosslinks and cell death. Once that payload is released from that linker product. This is currently FDA approved for relapsed and refractory large B-cell lymphoma. Dosing is here on the slide, calling out that it is dosed on adjusted body weight for those that have a BMI greater than 35 kilos per meter squared. That's a Wisconsin unit, of course. Pre-medications are noted here on the slide as well. This one does require corticosteroids starting a day prior to therapy. You can see that the dosing is heavier in cycles 1 and 2, kind of as a pseudo load. And we're really looking from a toxicity perspective at quite a significant count suppression. Those are all grade 3 and 4. Anemia, neutropenia, and thrombocytopenia rates, so relatively high here. And then liver function test abnormalities are quite significant here as well. But this was a recent FDA approval in the last 2 or 3 or 4 years for relapse refractory diffuse large B-cell lymphoma as a single agent. So we don't have a lot of those. We have a lot of chemo combinations, but after things like R-CHOP and things like that, we don't have a lot kind of in our armament. So it's nice to see some of these more contemporary approvals in a disease that does need more single agent options than those that have been heavily pretreated. Along the same lines, at roughly the same time, tafasitamab came out, again, another CD19 product. This one is a monoclonal antibody, no antibody drug conjugate here. This is, again, approved for relapsed and refractory diffuse large B-cell lymphoma. A little more onerous dosing, especially in those that are heavily pretreated, and you want to keep them out of the clinic as much as possible. This has a pretty significant burden of clinic time and chair time associated with it, but the dosings here on the slide, as you get into cycle 3 and beyond, it goes to every other week dosing, which is nice as compared to twice a week dosing in that first cycle. Pre-medications are here on the slide. This is FDA approved in combination with lenalidomide, so kind of a mAb plus IMiD combo here. The toxicities are on the slide, and I will call out a couple. Infections are significant here with this combination. Severe or serious infections are noted at 26%, or 1 in 4. Though in this heavily treated population, if you cut the lenalidomide, which they kind of had to do in some of the clinical trial patients, they found a decrease in grade 3 and 4 adverse events, decreased from 70% to 29% with the single agent tafasitamab. So though it is FDA approved in combination with lenalidomide, you may see patients on just single agent tafasitamab just to improve tolerability. Maybe one of those settings where you have an older, frailer patient who you maybe start with tafasitamab and add on the lenalidomide if they were to tolerate therapy as a single agent, perhaps. Back to our antibody drug conjugate combinations here. Inotuzumab ozogamicin is a CD22 targeting monoclonal antibody. This is paired with a calicheamycin payload. We've seen calicheamycin on a couple of the other ones already. Of course, that is cleaved within the cells that express CD22, leading to minor DNA grooves and inducible double-strand cleavage and cell cycle arrest. This is FDA approved for relapsed and refractory B-cell ALL. The dosing is here on the slide. As you can see, pre-medications are pretty significant, and you want to ensure that your patient is well cytoreduced. So you're targeting less than 10,000 cells or 10,000 blasts. So you really want to take the time to cytoreduce your patients as much as possible, as required by the package, actually, by the FDA, using hydroxyurea or steroids and or vincristine to try and decrease that risk, because there is kind of this significant TLS risk that comes with this product. So you want to ensure that you kind of tamp down that disease as much as possible on the front end. Toxicities are here on the slide. Peripheral neuropathy is a big call out here. Liver function issues are a big call out. That kidney function decrease is called out by the serum creatinine increase in almost all patients that were on the clinical trial. I feel like we see this drug every once in a while, but it has kind of been moved down the pecking order for those that have relapsed refractory B-cell ALL due to other therapies that we'll talk about kind of coming up. Back to our diffuse large B-cell lymphoma relapsed refractory products. This is polatuzumab. Polatuzumab is another antibody drug conjugate. This one is targeting a new mechanism or a new target, CD79. This is in combination with an MMAE payload, which we've already talked about as well. This is dosing on the slide is once every 21 days, which is nice. The FDA approval is in combination with bendamustine and rituximab, so kind of that BR plus POLA or POLA BR is the regimen. Though I have seen our lymphoma providers give this agent as single agent, again, in those more heavily pretreated or older and frailer populations, as a single agent, and then potentially adding in the BR components if the patient tolerates it, or just going single agent with this kind of novel mechanism or novel target, hoping to kind of treat the patients in a longer, less aggressive manner. So that has been used as well, but I've also seen the combination with Pola-BR, all three products put together. This kind of triplet Pola-BR does require PJP and HSV prophylaxis. Package insert recommends TLS prophylaxis as well as growth factor support. Though if you're doing just Pola, some of those don't make a lot of clinical sense just as a single agent. The toxicities are, again, in combination with that triplet, so just keep that in mind with regard to the count suppression. But peripheral neuropathy can be significant here. We're talking about electrolyte abnormalities and liver function issues, as well as, again, kidney function issues in those patients that may have a lot of disease here, hence the TLS prophylaxis call out. I did want to include tagraxofusp, though this product is not a monoclonal antibody. I wanted to call it out as a hematologic product that does target a specific receptor, in this case CD123. Again, this is not a monoclonal antibody, but it's actually a CD123 directed fusion protein of IL-3 fused to a catalytic or translocation domain of the diphtheria toxin. So you kind of have this protein linked with diphtheria. It's internalized, leading to internalization of those cells that express CD123, leading to inhibition of the protein synthesis pathways and apoptosis of those targeted CD123 expressing cells. This is FDA approved in a relatively rare malignancy, the blastic plasmacytoid dendritic cell neoplasm. That is its current and only FDA approval. Dosing is here on the slide. I am calling this product out for a couple of different reasons. Again, it's kind of relatively weird and unique in its mechanism of action. It's approved for a relatively rare malignancy, though since we are an NCCN designated comprehensive cancer center, we do see these patients. The dosing is on the slide. Dosing is 12 mics per kilo, so tiny dose. This is an IV therapy, days 1 through 5 of a 21-day cycle. You can see the pre-medications there are heavy, and they're actually more than we would typically see with any of our other products. It does require inpatient administration for at least the first cycle, and you really should consider multiple cycles if it does not go well on the first cycle. Serum albumin must be confirmed to be 3.2 grams per deciliter or higher prior to the first dose. Again, not something that you would typically see as a dosing restriction for any of our other therapies. And then all of this is really getting to the point that capillary leak syndrome is quite significant with this therapy. You are giving diphtheria as a therapy. So capillary leak in greater than 50% of these patients, hence the albumin restrictions and making sure that these patients have good oncotic pressure. Hepatotoxicity is almost assured for all of these patients. It's going to obviously cause third spacing of fluids and require lots of hydration for your patients and things like that. So decreasing albumin is going to be right in there. Pancytopenia is very common, grade 3 to 4 pancytopenia, up to 50% of these patients. Hypersensitivity reactions, hence all the pre-medications, fevers. So this is kind of a weird therapy for a weird disease that I just wanted to call out, even though it's not a monoclonal antibody, because it is a directed hematologic malignancy product that kind of should give you pause when you see it because of all of the weirdness that comes with it. Getting into more classical things, daratumumab, transitioning to some more monoclonal products for multiple myeloma. Daratumumab has become kind of a cornerstone here for multiple myeloma. This is an IgG1 monoclonal antibody against CD38, which is expressed on multiple myeloma cells, leading to apoptosis via different mechanisms, including cellular-dependent cytotoxicity, antibody-dependent cellular cytotoxicity, as well as antibody-dependent phagocytosis. It was historically approved for the relapse refractory multiple myeloma setting, really started as even as a single agent way back in, I think, 2015 for its FDA approval. And it's worked its way earlier and earlier and earlier, and in combination with several therapies, now with a newly diagnosed myeloma indications, and kind of, again, continues to be one of the cornerstone therapies here for myeloma. Was originally approved as an IV product. The IV product, of course, still exists. It was dosed per kilo. The dosing is here on the slide. We were doing lots of interesting things when it was first FDA approved. Because of all of the hypersensitivity and infusion-related reactions that we were seeing, we were giving the half dose over 2 different days and having the patient come back the next day for the rest of the infusion. Or we were doing infusions that were 8+ hours of chair time just to kind of get the first dose in. But thankfully, someone came along and formulated it as a subcutaneous product. Since that FDA approval went through, it is now, instead of being weight-based dosing, it is a standard dose of 1,800 milligrams, co-formulated with hyaluronidase as a subcutaneous product. You can see the dosing here on the slide. Still requires pre-medication with Tylenol, famotidine, Benadryl, all these sort of things. But you no longer have to do like the 8-hour chair time infusions and all of those sort of things. And I think the tolerability and kind of the patient ease has been quite a game changer for this product, which again has become a cornerstone of therapy for myeloma. Call outs there for toxicities, as you can guess, count suppression is quite significant, infusion-related reaction is quite significant. One of the other things is that it interferes with cross-matching and RBC antibody screens. So anybody who's going in for transfusions or possible transfusions, that needs to be called out and identified by kind of the blood bank when they go through that, because CD38 is also expressed on red cells. Looking at kind of that IV versus sub-Q product thing. So again, the drug manufacturer had it as an IV product. They then came up with this subcutaneous product. They wanted to prove that it was kind of the same from an efficacy and safety perspective, and then easier to administer. What they found in this kind of big comparison that was published in 2020 was that they found that the subcutaneous product had non-inferior efficacy as well as pharmacokinetics, despite looking at different body weight subgroup populations. That's what you really worry about with these subcutaneous products. And they had improved safety profiles in those patients that had relapse and refractory disease. And as you can see on the bottom left-hand side, those patients who were using the subcutaneous product actually had a higher satisfaction with therapy. So these patients liked it better, and it was non-inferior from an efficacy and pharmacokinetic perspective. Another CD38 product, though we do not use this one commonly at UW Health, is isatuximab, again targeting CD38. This is kind of what I think of as a Me Too product. We'll talk about a few more of those as we go along. This is approved in the relapse refractory setting. Dosing is there on the slide. Of course, it interferes with that same cross-matching and RBC antibody screens, but by and large, this is basically daratumumab's kind of little sister that no one really utilizes, or at least we don't utilize regularly at UW Health. Elotuzumab, another monoclonal antibody that was a relatively recent approval for multiple myeloma, came out roughly the same time as isatuximab. This is a IgG1 monoclonal antibody that targets a different mechanism or a different target. Here we're talking about SLAMF7. This leads to activation of the NK cells and antibody-dependent cellular cytotoxicity. So again, different mechanism, slightly approved in that kind of single agent relapse refractory. Toxicities are a little different as well. It has more effects on cardiovascular issues, so affecting heart rate, affecting blood pressure, and then also some immunogenicity concerns here, whereas 36% of patients might have some sort of immunogenicity problem with this product, including 6% of patients developing neutralizing antibodies, which isn't a great step in the right direction. So I will say that we do use this product at UW Health, though it is kind of further down the pecking order, especially with some of the more recent approvals in the myeloma sector for relapse refractory disease. Now we're going to quickly pivot to the bispecifics. This Up until really this last calendar year was a very lonely and empty section of the slide deck. It really was only including this bispecific here on the slide, the blinatumomab product. As a general kind of graphical depiction here, you see a double monoclonal antibody here, one against CD3, CD3 being a call out for T cells, and then CD19, which can be expressed on B cells. And what they found when you put these combinations together is you basically bring together your T cells, which were floating around and not doing a lot against your malignancy. You bring it in combination with your malignant cell, kind of put them within close proximity, and hopefully lead to T cell activation, T cell cytotoxicity against that malignant cell, and then the cytolytic synapses and hopefully apoptosis of those malignant cells. So you're kind of forcing your T cells to get activated against that malignancy where they weren't typically being activated against it. So again, the poster child here is blinatumomab. Blinatumomab's been approved, for almost a decade probably at this point. It again expresses against CD19 on B cells, CD3 and T cells, bringing them together. The FDA approval is here on the slide. It's for the relapse refractory B-cell ALL population, as well as ALL patients that are MRD positive, though they had good response or good disease response to previous therapies. Dosing's here on the slide. It's really 4 weeks on, 2 weeks off. If you are starting it in someone who has a burden of disease that's higher than MRD positivity, we're starting at 9 micrograms continuous infusion per day. And that's going daily for 7 days. And then we will escalate to the full therapeutic dosing of 28 micrograms per day as a slow infusion. And that covers your first 4 weeks. And then for those that are in cycle 2 or just MRD positive, again, lower disease burden, you can start at the full therapeutic dosing of 28 micrograms per day. With pre-medications here on the slide, dexamethasone kind of being the poster child. This does require hospitalization for initiation of doses as well as dosing ramps. Pre-medication requires that high-dose corticosteroids. And because it is a continuous infusion with IV central access for 4 weeks out of a 6-week block, there is a logistical issue associated with this product. You have to go send the patient home with these large bags that are infusing over slow periods of time. When patients have fevers and things like that, which you can see on the slide is not uncommon, if they present to their outside ERs, there's concerns about if the patient goes in, the typical thing that the nurses will do, they'll be flushing the line and then drawing labs and things like that. But if you have a slow infusion of this product over 24 hours and you flush that line with several hours worth of drug administered over a period of a minute or so, life-threatening CRS is very common or can certainly happen in that setting. So we've had issues kind of associated with that, and there's a lot of logistical work that goes into ensuring safe use of this therapy. We've had a lot of folks who have had neurotoxicity associated with these therapies. So there's a lot of call-outs associated with blinatumomab. We've been using it again for almost a decade at this point, and we're getting much better with its use, but it does have all of these kind of hurdles and issues associated with it still. Moving on to the more recent FDA approvals, I'd say the next 4 or 5 agents have all been approved within the last 18 months or so. Teclistamab, I would say, is probably the one that we've used the most at this point. I believe Mike Fallon told me that we have over 20 patients who have received doses, over 200 doses so far administered. For teclistamab, this is a bispecific that targets BCMA. BCMA is a receptor that's expressed on myeloma cells. So one side expressing BCMA going after myeloma cells, one side expressing CD3 going after T cells, trying to bring those cells together and have them create that cytolytic synapse and work those T cells against that malignancy. Currently FDA approved in the relapse refractory setting, though you know that they're studying it, of course, for earlier and earlier therapy. That's how these things work. The dosing schema is here on the slide. You kind of have 2 step-up doses before you hit your treatment dose. This requires hospitalization for ramp-up as well as re-ramp-up. Those ramp-up being those step-up doses that are here on the slide. Due to the risk for life-threatening or fatal reactions such as cytokine release syndrome. So whenever we activate those T cells, we have the risk of kind of overactivating those responses, leading to cytokine release, which we'll talk more fully about during the CAR T section coming up. Um, but these patients, during this ramp up as well as during treatment, are at risk for cytokine release. Additionally, there's a black box warning for neurotoxicity, another response that we see with those T cell activations. So we do have that concern here. Infections as well as injection site reactions and fevers are relatively common for this subcutaneous product. Though, again, in combination or in the context of blinatumomab, this is a subcutaneous product. It's administered only once weekly. It doesn't have kind of the line flushing or having to need a central line for an entire month and all those other complications associated with it. It's currently single agent against multiple myeloma as well, with a decent response rate versus that relapse refractory disease setting. So it does have quite a significant role here. And again, we've had 20 plus patients in the last, I don't know, 6+ months. So pretty big uptake, I would say, at this point. Very much kind of in that same vein, almost what I would say is a Me Too product here. Elranatamab is basically Pfizer's version of teclistamab. It's a bispecific, targets BCMA, same mechanism of action, has the same kind of step-up dosing that you saw with teclistamab as well, requires hospitalization for that ramp and re-ramp just like teclistamab as well. Dosing differs slightly, of course, by dose, but also this includes the option for bi-weekly or every other week dosing after week 24 if they've maintained a response for 2 months or longer in that first 24 months. So there is an option here per the package to dose them every 2 weeks. What I would say is teclistamab, that may be happening in the clinic anyways. But this is an FDA labeled dosing associated with that, whereas teclistamab would be off-label dosing for every other week dosing. Patients, in the relapse refractory setting don't want to be here every week if possible. So that is a labeled kind of benefit associated with elranatamab. Does have the same black box warnings that we talked about with teclistamab with cytokine release and neurotoxicity as well. And then the most recent FDA approval of a bispecific in myeloma. It's kind of funny, a disease that historically hasn't had a lot of therapies. All of a sudden, we've got in the stretch of 6 months or 12 months, 3 bispecifics, which is kind of funny. Talquetamab is a monoclonal antibody by the same manufacturer who makes teclistamab. This bispecific actually targets a different receptor. This is GPRC5D, which is expressed on myeloma as well as keratinized cells. Same mechanism of action, bringing those malignant cells closer to the T cells and activating those T cells. Dosing and concerns are going to look very similar to teclistamab. Again, it's the same manufacturer, and they actually use the same REMS program, so it's kind of all bucketed together. Bi-weekly dosing schema does exist for these patients, which is nice. So again, unlike teclistamab, this one does have an FDA labeled twice or every other week dosing schema associated, but it still does have that black box warning for cytokine release, neurotoxicity, hospitalization required for ramping and re-ramping, and with the combination in that different receptor comes with some different toxicities as well. So these are kind of some weird ones associated. We have a lot of dyschezia, weight loss, skin and nail related complications. You can basically have patients who don't have a taste anymore. You have pretty significant weight loss associated with this process. And I really want to call out on the right-hand side, this slide stolen from Mike Fallon, that the onset and the potentially no resolution of these toxicities may be quite limiting to patients' tolerability or willingness to do this therapy in a relapse refractory setting. So there's a lot of toxicities and a lot of management that needs to go into the folks who have received talquetamab. We actually have our second patient currently admitted to B66 for this therapy getting started. So we don't have as much clinical experience here as we do with teclistamab, but it is, of course, another therapeutic option. Moving quickly, glofitamab is a bispecific that is targeted towards CD20. So we're bringing in the bispecifics now for CD20. This is approved in the relapse refractory setting for diffuse large B-cell lymphoma, technically in combination with obinutuzumab, though the obinutuzumab is really kind of a run-in, where obinutuzumab is given as a single agent on cycle 1, day 1, and then the rest of the dosing is just glofitamab going forward on the slide here, as you can see. This requires hospitalization for the first ramp-up dose, that day 8 dosing, and it does have a black box warning associated with cytokine release syndrome, as you've seen with all of these other bispecifics at this point. So calling this one out as a bispecific for the relapsed refractory diffuse large B-cell lymphoma section. Another one in that same vein is epcoritamab. Epcoritamab, again, another bispecific, again, targeting CD20. So kind of in that, again, same vein for a Me Too sort of idea. The dosing is here on the slide, and this, of course, also requires hospitalization for this first treatment dose, as well as re-ramps. These have black box warnings of also for cytokine release syndrome, as well as neurotoxicity, and then major infections can happen in these patients as well. Dosing, I will call out, after cycle 3 can be decreased to every other week, and then cycle 10 and beyond, it can actually be reduced to once a month or every 28 days. So that is kind of a nice benefit for your patients who, again, want time away from us here in the healthcare setting. And then I think one final bispecific here, this is mosunetuzumab, another bispecific, another one targeting CD20. This one is FDA approved for follicular. Does not require hospitalization per the package insert here, though it's one of those things where I believe we hospitalized our first one just because it was new for us. But it does have a black box warning here, and the CRS or cytokine release syndrome risks are quite significant here as well. But another therapeutic option, this one in follicular lymphoma, for those that need kind of relapse refractory dosing. I do want to quickly move on, since we're already running out of time, for the CAR T-cell therapies or immune effector cells. If you don't know, which you probably do, CARs are special receptors created in a lab that are designed to target proteins on cancer cells, and they're inserted or added to your patient's T cells to help them find and kill cancer cells that are expressed by that protein. This is the utilization of genetically altered or engineered patient cells that are used to fight these diseases. Currently, the only FDA approvals are for autologous cells or cells that were collected from your patient, though allogeneic cells are in investigation right now. These are pitched as living drugs that are targeting your patient's specific malignancy, inserting that malignancy-directed receptor onto the T cell. They're engineered to express these CARs in the lab or ex vivo, and they're expanded in a production facility to reach an adequate quantity before infusion to your patient. The goal here really is to have these cells engraft and proliferate within those patients, so it's not like a one-shot thing, but they kind of grow and persist, and they continue to surveil in your patient to eradicate your tumor, but also promote immune surveillance to prevent recurrence. That's kind of the goal or the optimum for these products. Here's a quick graphical depiction. I won't spend too much on it because we do have very little time at this point, but your patient needs to be leukapheresed or have their T cells collected off. Those cells are shipped off to a factory. Those cells are modified using viral vectors to insert that receptor into their surface that they weren't previously expressing or not expressing it on a high enough rate. We kind of expand those modified cells in the lab, ensure that they are expressing the cell receptor that we want and in the quantities we want. They're shipped back, or give a little bit of lymphodepleting chemotherapy to kind of clear the deck a little bit, and then we re-infuse those cells back into your patient. That process can take a lot of time. There can be lots of failures associated kind of along that pathway, but if it all goes well, hopefully your patient will receive their cells within a month or so after collection and have those cells persist and work against their malignancy. We have currently 6 FDA-approved products. The first 4 are all targeting the same receptor, CD19. All of them are in some various combination associated with diffuse large B-cell lymphoma or follicular lymphoma or ALL. They all use different viral vectors to make them happen, like a lentivirus or a retrovirus, as you can see on this slide. The doses of the cells are kind of on the same relative spectrum. They all require pre-medications prior to giving, and they are recommended to avoid prophylactic steroids or steroids as much as possible, as steroids can be toxic against T cells, including these CAR products, And they all have very high wholesale acquisition cost, or WAC pricing. Some of these products are up to $500,000 WAC pricing. Patient charge can be much, much higher than that, of course. The first two, are Tisagen Lec-Lucel, or Kymriah, and Axicaptogene Silolucel, kind of the first two here. Brexacaptogene Autolucel, or Tecartus, has mantle cell lymphoma approval on that, and Lysacaptogene Marolucel has the primary mediastinal B-cell lymphoma approval as its FDA-labeled indications. Two CAR products for multiple myeloma, so targeting BCMA, which we talked about for some of our other therapies already today. Isacaptogene Vic-Lucel, or Abecma, has been our UW product of choice. Carvykti, or ciltacaptogene, is coming down the pipeline. I think we have our first one coming up in a few weeks here. So we've historically used the Abecma product. Cilta-cel is coming down. And then the other ones, I think we've used all of the other CD19 products in various combinations. Picking one or the other is difficult. A lot of it is going to be restricted by the manufacturer and whether or not they have actual slots, time slots available to make your product. So that may change kind of which product you choose for your patient based upon kind of what's available and what the insurance will allow. Efficacy. So these products, again, this is typically used in a relapse refractory setting where chemotherapy or more traditional interventions have failed. So your patient is kind of a refractory disease, chemo's not working, et cetera. So the hope here is that you're treating chemo refractory disease, and you can hopefully kind of come at it with a novel mechanism with cells that continue to persist and grow and surveil that body as well. But again, treatment failures all of this sounds great in theory, but in practice, there's a lot of treatment failures that can come on. We can have progressive disease despite CAR T cells kind of growing and persisting. We can have your tumor cell stop expressing the receptor that we're going after. It can just stop expressing CD19. Once you have a CAR product going after CD19, you can kind of have that clonal evolution and loss of receptor to CD19. Those CAR cells may not grow and persist in your body like you want them to, and they may actually just die off. So there's a lot of toxicity or other kind of reasons why CARs haven't been maybe as hopeful or efficacious as we were led to believe kind of on the front end. But there's a lot of ongoing studies, particularly in heme malignancies, though there are some solid tumor studies ongoing as well. Toxicities can kind of be all over the place. We talked a little bit about cytokine release, and we'll talk about it more kind of as we go. There is concern for potential mutations or oncogenesis whenever you're manipulating DNA. Neurologic toxicities, we're going to talk about a bucket called ICANS coming up, but that is a concern here as well. You can have on-target but off-tumor toxicities. So if you're going after CD19, you can see those on malignant cells, but you can also see them on normal B cells. So in this example, you've killed off all of your normal B cells as well, causing B cell aplasia. Then you're basically losing that humoral immune response. And then, of course, there's things like infusion-related anaphylaxis or allergy responses to foreign proteins. So this is kind of like a large bucket of toxicities associated with CAR. The biggest two are really cytokine release. Cytokine release syndrome is a constellation of inflammatory symptoms resulting from cytokine elevations. In this case, the cytokines are derived from infused CAR T cells or other immune responses derived from those CAR T cells and activation of those T cells more globally. So when we're talking about our bispecifics, we're talking about bringing those T cells together with the malignancy. Those T cells kind of get activated, get grumpy, and we have kind of these inflammatory cascades kicking off. Same story here with the CARs product. With the CARs, the severity of cytokine release syndrome is correlated to the elevated levels of those cytokines within the patient. Peak ferritin and CRP are inflammatory markers. Higher blood levels of CAR products, so those CAR products that activate really well and replicate really well, that can lead to or be correlated with higher CRS. And then a higher malignancy burden. So there's more T cells, more malignancy to kind of put together, and that activation is more significant. All of that leads to more severe CRS. CRS can really look like basically anything within this chart here, but we'll really call out fevers, tachycardia, hypotension, kind of those circulatory kind of sequelae. Here is the ASTCT CRS grading. We're really talking about kind of three big buckets: fever, hypotension, plus minus vasopressors, and hypoxia. Kind of how you grade this out, grades 1 through 4. Almost all patients getting CAR products and bispecifics even will maybe have a little bit of fever, maybe a little bit of hypotension. It's all about like on that spectrum, kind of where they fall. Here is kind of a nice breakdown of our UW guideline for the management of CRS associated with CAR T. We actually have this guideline. We also have a bispecific guideline for the management thereof coming as well. So UW does have some resources associated with the management of these products. Also, the package inserts are a good place to go if you're ever kind of in a pinch looking for the management of these toxicities. I will call out, basically, if you look here on the slide, giving antibiotics, kind of ruling out infection, all those things are kind of first line. Giving fluids and maybe even low-dose vasopressors. The administration of corticosteroids and tocilizumab is kind of the big decision points and where you administer those products and kind of where that comes from. But that is really something to call out and kind of a patient-by-patient, kind of case-by-case basis, where this guideline tries to distill that down as much as possible. The other big toxicity associated with CAR T is ICANS, or immune effector cell associated with neurotoxicity syndrome. This is a clinical and neuropsychiatric syndrome that can happen days or even weeks after CAR T infusion. It can also happen again with those bispecifics. Some proposed mechanisms here, we're looking at passive cytokine diffusion within the brain. So, this has been correlated with high serum levels of IL-6 and IL-15. And they've also found folks who have significant ICANS having those trafficked CAR T products into their CNS as well. Presentation can be anywhere from a headache and tremor all the way up to seizures and edema. And it's relatively rare to observe severe ICANS without CRS. So it's kind of sometimes kind of go hand in hand for our patients. ICANS grading is here on the slide just for your reference. We also have the pediatric grading that's coming up as well. These patients are assessed kind of doing their where are you, who's the president, can you repeat this sentence back to us every 8 to 12 hours? And that's kind of graded kind of on a scale kind of as we go. And that's your kind of your first leading indicator for ICANS for these patients. Then pediatric grading is here as well. The STCT consensus grading, a good reference for you if you're ever managing these patients. ICANS management is typically supportive in nature. You're going to be treating elevated intracranial pressure and seizures per your standards of care. Keppra is very common, and we'll consider seizure prophylaxis for folks who are maybe at higher risk or who are showing low-grade ICANS. Tocilizumab, an anti-IL-6 monoclonal antibody, which was used quite significantly for the COVID pandemic, has a lot of use here for CRS as well as particularly CRS, but it's typically not used only with ICANS, only with CRS is concurrent. I said that that's relatively common when they are concurrent, but not always. Early steroid use is really the big intervention that we have for ICANS management. Sometimes it just takes the tincture of time to help these folks with ICANS. Heavy corticosteroid use is kind of the other intervention that you have in your back pocket for these folks. And then more contemporary in the last 12 to 18 months, the use of anti-IL-1 anakinra has kind of been more highlighted, I guess, in the literature. We have included this within our CAR T management guidelines now, both for refractory CRS as well as refractory ICANS. The dosing varies in the literature. We happen to be a little more heavy on our dosing here at UW Health as compared to some of the literature. So be sure to check kind of what the literature dosing was if you're looking to kind of compare apples to oranges with our products. And then I just want to call out, I've been a little pessimistic on CAR T therapy globally just because of, it's pitched as a great therapy for these relapsed refractory folks who are not responding to chemotherapy. We haven't seen, I can't overly generalize, but I would say the efficacy hasn't been super stellar, and it does come with a lot of toxicities, at least in my anecdotal practice. But there are a lot of moves that are coming down the pipeline that will hopefully make this more broadly available to patients, hopefully cheaper for patients, and hopefully more efficacious and safe. Calling out improving access to these products. So off-the-shelf allogeneic CAR T products would eliminate some concerns. A lot of patients won't be able to mobilize enough T cells to actually have these products made. You need to have enough viable T cells shipped off to the manufacturer to even be a candidate to have them manufactured. And if you can't make T cells, then you can't have these products made for you. But if we could use allogeneic off-the-shelf products or off-the-shelf cells that are already ready to go, you don't have to wait the month for these products to be manufactured and shipped back. You don't have to worry about getting enough CAR T cells, and then hopefully the lab's able to convert enough CAR T cells over for you. So it gets rid of that manufacturing failure and viability concern. And we do actually have a allogeneic CAR product that's on investigation here at UW Health. It's a Fate Allo CAR product. I believe it's CD19 targeting. Hopefully we can improve the control of these products. So we have had kind of runaway CRS or ICANS where they're kind of relapse or they're refractory to kind of our interventions, and we don't have good control over these. We've actually had a couple of deaths associated with some toxicities. So it'd be nice to improve the control of our CAR products. One way to do so is to insert some sort of kill switch into those CAR T receptors, where you can give a drug and lead to the self-destruction of that receptor and actually turn off those CAR T cells if you're really in a bad pinch. A good example of that is inserting an EGFR kind of target to that CAR. And then if, grade 4 CRS is coming along and your patient's circling the drain, you could just administer something against EGFR. It'll cleave off that CAR receptor and it'll inactivate those T cells. And then hopefully we can improve toxicities, improve that on-target, off-tumor control, trying to get rid of those patients that have their complete B-cell aplasia, and keep that receptor targeted towards the malignancy and off of healthy tissues that we don't want to affect. So further work is moving towards kind of improving these patients, improving the proliferation and survival of those CAR cells, and hopefully this will continue to grow and evolve and improve in some of these kind of shortcomings that I've highlighted today. With that, we've really blown through a lot of content, but please reach out to me if you have any questions or concerns, and we have a few minutes in the chat if you have anything for me.